Hello everyone, so I'm going to do a quick case discussion today, talking through a case that we delivered recently using the concepts of avant-garde dentistry and the workflow for the injection mold technique. So I'm going to talk through this case from start to finish, starting with the patient's initial presentation, initial concerns, and how we executed what we did using the workflow. So we start with the full face picture. You can see that we've got quite a gummy smile and very small teeth, and the patient's main complaints were exactly that, really: the gummy smile, the size and shape of the teeth, the lack of anatomy and morphology, and she just feels like she's always had really small teeth all of her life, and she wants this dominance back to the lower third of the face. So if we look at the full face picture, we can see the midline isn't too bad, that's okay, but there's a lot of excess gingiva at show here, and the teeth are really small. So we think about expected proportions for this smile. The incisal edge position is pretty good, nothing wrong with the position of that, but really small, short teeth, lack of proportion. So the first thing that we want to think about with the design is instilling correct shape to the teeth. Very triangular, short, pointed, very worn, evidence of attrition, and recreating a gingival height of somewhere around this region here to fill in all that pink and introduce a nice proportion that we're looking for of the tooth. What we did was we took all this information, we did a digital intraoral scan, we sent all the photos and the scan to the lab, and we communicated these issues to the lab to come up with a 3D smile design so we could create a motivational mock-up for the patients. So just to reiterate, the main things were, the shape of the teeth, you can see, very pointed and sharp, the height of the tissues, and the gumminess of the smile. And intraorally, when we look at the attrition and the wear, you can see the wear facets, how we're getting very thin on the incisal edge and translucent, and corresponding wear on the lower teeth. And you can see this attrition there in the canines, which was evident when we look at the articulation of the mouth. Left and right canine guidance had been lost, and everything was just really flat. So we haven't just got an aesthetic concern here with this case, we've also got a functional concern. So there's an awful lot to go on here. We've got to think about the correct tooth shape, size, proportions, the ideal smile design for the patient, how much crown lengthening is going to be needed to achieve that, and how do we reorganize the occlusion so we can reintroduce a predictable function with the correct anterior and canine guidance to prevent any further sort of risk of this wear or fractures of the composite veneers. So we went to the design and we created a mock-up to trial and test in the patient's mouth and make sure that we're going to get all of these things right. So, to the mock-up, full face. Looking at that first, we look at the new incisal edge position. Length is pretty good, everything's been leveled off and squared off. The lateral incisors and the canines start to take a nice form and shape. There's nice volume to the smile, and you can see that all this gumminess and excess show of the gingiva has now been taken away. So from an aesthetic smile design point of view, have we ticked all the boxes? Have we improved the proportion? Yes. Have we got the incisal edge position right? Yes. Have we got the gingival zenith new position right? Yes. Tooth size and shape, great. So now we can use this mock-up to guide our crown lengthening for the new position of the gingiva. The next things we want to have a look at is the new occlusion. And because this is an additive case for composite veneers, the first mock-up should be a true indication of where we are with the function and the occlusion. And you can see here on this image, the lower mock-up has also been placed, and we will use this to check all the contacts and occlusion and all the new guidance and articulation in the mouth to make sure that we're happy that what we're going to create in the composite veneers is a true replica of the mock-up. If there's anything to be altered at this stage, we'll go back to the lab, we'll make alterations, and in a case of this complexity, we would do a second mock-up to double check all of these things until we're 100% sure that when we go to execution of the case, which is irreversible, that all of these things have been sort of triple checked and we're happy and confident they're going to be 100% right. So in this case, we got it right first time. Bite was fine, all of the guidance was fine, tooth shape, size and proportions were fine. So the next stage was to move to the crown lengthening. We communicated with our periodontist via these photos, via discussion over the mock-up with the patient's mouth, and the periodontist uses the mock-up for their guidance of where they want the new gingival position. He'll use a scalpel, or he will use a laser to scallop around the mock-up and create the new shape for the gingival position, and then he will raise a flap and remove the necessary bone for the crown lengthening procedure. And just a quick image, this is our image on the day after crown lengthening, and you can see already the new heights and the teeth are starting to take shape with regards to the height to width ratio and proportions. We then leave that for 2 weeks and we remove the sutures, and we need to give it a total of 8 weeks healing time after the crown lengthening before we can execute the injection mold technique for the digital composite veneers. On a 2-week review, we will rescan the mouth with the intraoral scan to record the new gingival position, and then the lab can create what's called a final design mock-up for the injection mold technique. This final design will be adapted to the new gingival position. And then we have a nice accurate stent created, which we'll show you in a sec with the workflow, which is going to allow us to create these veneers really accurately with nice margins and really good adhesion to the tooth. So the day of treatment execution for the injection mold technique is how the patient presented. You see the gingival condition is nicely healed and the tooth proportions are starting to take shape with the crown lengthening completion, but we've still got, you know, the wear and the tooth shapes to improve, which you've seen that improvement through the mock-up. So first stage is what we call stage 1 isolation, where we isolate every second tooth out of the 10 that we're going to treat with some PTFE tape. Then the teeth which are left behind then undergo the process of etch and bond, with the third stage being application of stent 1, ready to inject heated composite into the channels of the teeth which have been prepared. So we go ahead and do that. So the stents are specifically designed to allow a perfect fit of the composite capsule from Ivoclar Empress Direct into the stent, heated composite, heated on the Bryant dental heaters to around 60 degrees Celsius, gives a nice flowable consistency, and that's injected slowly into the stent individually, one by one, cured each time before the stent is removed again. Which brings us to this. Stage 1 bonding is complete. Every second tooth has been bonded, and some minor finishing, removing the sprue holes, which would be here, and some refinement and tidying up around the gums. From that point, you're then in a position to prepare for stage 2 bonding, which is isolation of the teeth which have been bonded, etching every second tooth again, bonding every second tooth, application of the stent, and injecting of the composite in the correct position. So this injection, it's a nice, slow Steady injection, not too much compression on the stent. The stents are designed to fit perfectly without too much excess. So it's a nice slow injection. It's only when you start moving the stent, applying too much pressure to the stent, will you then potentially want to force the composite into other areas that create excess. So it's a nice, steady, confident, slow injection, and just allow the composite to just flow down to the gingival margin and then backfill in the stent. Then we'll take on some final finishing. So my preference is to start with a high-speed burr with a couple of different burrs, mainly with a flame tip, interproximally and around the margins of the composite to make sure that everything's nice and free and smooth around the gingiva. Getting into these interproximal spaces with a flame-shaped burr. Smooth diamond. Then we can move with our serrated saw again, just to make sure that the interproximal contacts have all been correctly shaped and smoothened out, to make sure there's no excess connecting the composite, which there shouldn't be because the tape has already separated the teeth and we've injected independently every other tooth. The saw goes through. That just allows you to make sure your contacts are there and accessible. Then we can start to use polishing strips in the contacts, again to make sure there's no excess, no ledges, and everything is nice and smooth and nice and cleansable. Once that's done, I would then move to a very fine soft flex disc to make sure that any excess around this area where the composite's been injected in the sprue is nicely removed. I don't want to be using the soft flex disc too much on this surface, because this is a direct copy of the mock-up, which is a direct copy of the digital design. So all of the tooth anatomy, textures, line angles will already be there and present in the tooth, but you don't really want to be removing too excessively. The main focus will be to just polish these areas, which you'll see in a second. So the next thing is an enhanced finishing tip, where we'll use again all around the upper third of the tooth, just to shape and remove any excess and get a nice smooth margin, and just make sure that that emergence is how you want it to be for the composite veneer. And then we can move into the Optogloss from Ivoclar, the Optogloss polishing tools, to start to buff and polish the composite veneers. Very easy protocol. You can do this at a slow speed or sometimes at a higher speed with water at the same time on a tooth, and this will really bring out the polish in the composite. We like to use the Empress Direct for this reason. It's a strong composite but with very high polishability, which gives us really nice results in our finish. And there we are, we have the upper 10 composite veneers finished and executed. Nice smooth margins, all the excess removed, tooth shape and proportions have all been replicated from the mock-up. We know the patient's happy, so the mock-up's all been signed off. We know the occlusion's going to be good, we know the canine guidance is present, and we can confidently finish our case off. So that brings us to our final results. And there's the patient's full face. Everything that we prescribed in our original diagnosis for the mock-up has been completed. Correct proportions, very little gingival display now, exactly what we want. Incisor ledge position is great, tooth shape is great, the width and volume of the smile is great, and she really has that dominance now in the lower third of the face, exactly what we was hoping for. Close up to the smile. The shade of the composite used here was Empress Direct shade BXL dentine. It's nice sort of opaque dentine, white colour, which the patient wants. And as we say, with a nice polish and shine, it really gives a beautiful finish for that Hollywood smile look. Side view. Again, great volume to the smile. Nice shapes and portions of anatomy, which we didn't have before. Other side view. And you can see the lowers all nicely finished off there as well. These photos were taken on the day of treatment and a close-up retracted. So that's our case. These type of cases, you know, sometimes you can look at it and wonder where do you actually start with a case like this. You know, everything is essentially wrong. The occlusion needs to be looked at. It's essentially a rehabilitation case. Upper and lower teeth need to be treated. It's an additive approach for sure, because it's already where the teeth are already small. We don't want to be as conservative as we can, and the avant-garde workflow really allows us to plan accurately, digitally, trial and test things through our mock-up, which is totally non-invasive, communicate well with the patient for any customization, communicate well with the lab, and then confidently execute what is a very difficult treatment relatively easily just by following the protocols and the step-by-step stages which are needed. Like I always just like to say, it's a matter of just trusting the process, and the more of these cases you see and deliver yourself, you really start to understand how great this workflow is, and allows us to offer many patients answers to their dream smile, really, which previously they may not have been able to offer, or our patients may not have been able to afford. Thanks very much.